All right, welcome everyone. Very excited for another Residency Hot Topics. I'm especially excited for this one because Dr. Joe Godges is our invited speaker. Joe, in my estimation, is the godfather of residency and fellowship. He helped us begin our first residency program and numerous other programs across the country, was part of the early phase of residency proliferation, and has done a ton recently on clinical practice guidelines, being a huge contributor, editor to all of the first round, I believe, and is now helping to disseminate that and make it part of common practice among PTs. So, Joe, with no further ado, welcome to Residency Hot Topics, and the floor is yours.
Okay. Um, Let me get back to, so thanks, man. Trying to get my screen big again. Um, just doing the maximize. Something clicked and it went minimize. So I'm trying to get it back to the normal size. So, oh, there I go. Okay. Okay, crew. So normally I'm working with people I can see and I'm in front of, and I would typically say, hey, what have you, you guys have all had clinical instructors, you've had supervisors, and I would kind of ask, hey, what do you aspire to be? Which one would you like to be like, or what did somebody do or show that impressed you, that typically drove you to do a residency to say, hey, that's what I want to be like. Um, that's what this is about is, what are those master clinicians doing? Um, and just a little story. I've taught the residents at USC and I teach at other residency programs and the ones at USC come from every place at the class at USC, from Minnesota, from Montana, from Virginia, from Arizona. And I said, hey, what do you see in your mentors, your clinical instructors? And they gave me very interesting responses. I mean, it was very different. It says, they said, hey, that these clinicians that I'm working with, they don't even ask questions. They just sit there and say, hey, patient, tell me what's going on. And then just go, uh-huh, okay, go on, uh-huh. And then after about 3 minutes, they say, oh, it sounds like you have this. And by the way, tell me about this. This is maybe related. And they go on, and then they says, oh, well, it sounds like you have this. Let's start treatment. And then they do a little couple exams and figure out what's their relevant impairment. They figure out the intensity. Um, and then have the conversation with the patient. And most of the time, the patient's doing the talking. And the patient starts saying, hey, I think I should do this. I think I should do that. Okay. And the therapist says, good idea. And then they go. And then they're on target with hitting their most relevant impairment. So I thought, oh, hallelujah. That's what we want. That's different. And that's what therapists do. And let me advance this. There we go. Um, okay. So, and what makes that different than with the other therapists? And so I'll just start with this question and you guys can either answer. So one of your relatives grabs their chest and says, hey, they're having chest pain and they're having difficulty breathing. What do you do? I mean, do you question the competency of the paramedic, the ER nurse, or the ER physician and managing your loved one's condition, or do you assume a standard level of competency? Now, on the other hand, imagine you live in Virginia and one of your best friends who lives in Los Angeles calls you and says, hey, they hurt their back gardening or lifting or doing something. And after speaking to them, you said, hey, you should go to a therapist and they can help you recover. What do you do? I can tell you what a lot of people do is they send me a memo and they says, Joe, do you know a good therapist in Glendale or Pasadena or Santa Monica or Orange County? Da, 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 da. And I'm thinking, oh my God, why are we have so much variation in our practice that we can't assume somebody's a PT knows what they're doing and that we have to ask for what's good. And I'm thinking, oh my God, even instructors in residencies and fellowships and academic programs, what are we doing where we have such a big variation? And what should our professional organization do to try to make it more consistent? So that's kind of what drives this. And the little story that follows this, as Ben mentioned with the guidelines, is in 2003, Leslie Torburn, who was one of my colleagues in California who worked for the state comp insurance for it, she was asked by the insurance fund for the workers' compensation, said, what do we do when a PT's asking for more visits after they've seen somebody for 37 visits doing ultrasound to a client's heel pain? And then what the divisions of workman compensation did is they adopted the guidelines from the occupational medicine practice guideline group because there wasn't anything else. And that drove and told them, hey, this is what physical therapy is. And that kind of struck a little nerve. And so then Leslie and I went to the board of directors from the AOPT and said, hey, this is what's happening. Either we define our profession or somebody else is going to do it for us. And then the board said, we can't have that. Let's create our own guidelines. And they initiated a project in 2006 and invited 24 leaders in the field. You could probably know most of these names, basically the leaders of each region, and said, hey, can you come and decide if we should start doing practice guidelines? And then they appointed me because they figured I didn't have a real job and appointed me to lead it and be the volunteer to help guide it. And then they also said, hey, we should do it based on the ICF, and that should be the terminology and the reasoning behind it. And then we basically went to work. So you had this crew of army of volunteers that created guidelines, and from the head and neck to the shoulder and arm and to the elbow, wrist, and hand. And all of these are free access on orthopt.org and jospt.org. For low back pain, the different guidelines related to back pain, and then the different guidelines related to hip and thigh, the knee, and ankle and foot. And again, and what we're working on now is a guideline on the criteria that somebody who's working in a primary contact provider, actually for every physical therapist, who should they refer that has a problem that's mimicking musculoskeletal pain, but actually would be better off being treated by a medical or surgical practitioner. And so with all of these guidelines, there's these nice decision trees, and you may be familiar with these. And I point at the adhesive capsulitis one because it was done so well by Marty Kelly and Lori Mitchner and the crew driving this, and they've been copied by the other guidelines. And here you see it's this components of, hey, doing the diagnosis of physical therapy versus another medical practitioner. And then there's this rule in and rule out phase. So if somebody comes in, they have shoulder problems. Hey, what is it? What is it in of what makes it adhesive capsulitis problem versus a rotator cuff tendinopathy problem versus shoulder instability, someone after a dislocation or after overuse of throwing or something to that nature, what puts them in that category? What do they tell you in their history and their interview, and what do you find in your physical exam that rules it in and rules it out? What this group did, which was quite skillful, is like, hey, you got to do positive confirmation, but you also have to get rid of your confirmation bias and rule it out that it's not some other condition. And then it was this critical element of, oh my gosh, not only do you know the condition, but you have to know the tissue tolerance of that, because that's going to drive your level of examination. That's going to drive your level of treatment. And that's where you hear these words like irritability, but it's essentially that old Syriac sign of, hey, do they have pain before movement, end range? Do they have pain at end range, or do they have pain with overpressures? And how does that drive your intervention? And how does that drive your exam? And then that was a big thing for adhesive capsulitis, because then you have your interventions based on their tissue tolerance from high irritability, moderate to lower irritability. It was a big deal for adhesive capsulitis because many of the studies where people had the right categorization of the human, but they used the wrong intensity based on the irritability and ended up having a bad effect and caused inflammation and pain and with their manual therapy procedures, but it was mainly because of the dosing and not so much the categorization. So that was an interesting component where, and then you have these descriptions of, hey, if you, for example, you have moderate irritability, you kind of go into end range, but you got to be careful not to um, produce post-treatment inflammation and associated pain because you're just going to create more inflammatory process and more adhesions. So that was kind of driving it. And then the other guidelines, such as the neck pain guidelines, modeled that with this whole process of these different components. And then, hey, here are the conditions we know that tend to be that we have enough data in the literature to put people in classifications and match them according to their presentation and their physical exam, and then decide also on level of irritability, which is highly related to their tissue healing, acute, subacute versus chronic, and also and then match your interventions to that. So you'd match your interventions based on acute, subacute, or chronic. So that's essentially the nutshell of, let's say, where the guidelines are, is taking what's known in science and then trying to equip people with pattern recognition. And then the other component is saying, hey, by the way, this takes skill. This is not easy to pull off and to do well. And that's what would made me actually so, I don't know, I was kind of content for the first day residents saying, hey, here's what we want to learn. And I'm saying, hey, well, that's guidelines-based care, but that's guidelines-based care, not necessarily using the Betty Crocker cookbook version, but using the Wolfgang Puck version where you're really doing it well. So any thoughts, comments, or questions you can put in the chat, and then Ben will be monitoring that and bringing up of elements that you have. So as we go, we can kind of make this continue to be interactive. Anything at the moment, Ben, or we're good?
So far, so good.
Okay, let's continue. So now, so in 2020, which, as you kind of remember, this was right when COVID hit, but before that, as we were planning for it, there the some leaders that were invited to give this presentation. And the key of this presentation was integration over isolation, because these different residency directors said, we're having trouble is that people aren't knowing how to put the guidelines together. As the comment in the was just in the chat that say they're a little bit difficult to read, they're not knowing how to interpret them, they're not knowing how to implement them. And by the way, they're not sure how to use, when should they use the neck guideline, when should they use the concussion guideline, when they should use the shoulder guidelines. And so we said, okay, we got to help. And so we put this whole program together, and we put the content of it actually in a whole practice guideline package, which now is becoming available for free for all ortho section members or APTA Orthopedics. And it's included in the practice guideline package, which is being rolled out month by month or month by every other month. And the first component of this integrated decision tree was the first component. And it was basically pushing this envelope of, oh, by the way, here's the skills you need, here's the reasoning, trying to make these guidelines come alive rather than the process of what it goes through of a systematic review to have a guidelines you can trust to actually get published in a peer-reviewed literature. So we're trying to make this open. And the premise is that there's this value of summarizing in an unbiased way, and that's part of what makes them kind of dry to read, is this unbiased component. There's a value to knowing that and have the knowledge and the recommendations be public, but it also takes a high level of skill to implement it and a high level of knowledge of integrating that into your practice. And so kind of the take home point, which I'm going to continue to say, or this is my kind of my mantra, which is kind of like, hey, you got to really have skills to look at the psychological factors, make decisions about that. You got to have skills about classifying people into conditions that they match, that respond to match interventions. That's the nutshell of the whole thing, is actually match the right treatment to the right human at the right time by the right therapist, and you'll do fine. But doing all those four things isn't that easy. Know about the level of physical and mental impairments and figure out what's relevant. Even though the guidelines say, hey, these six things are associated with a particular condition, such as adhesive capsulitis or neck pain with headaches. You don't do all six. You probably do one or two that's relevant to this condition. And identifying which one or two is takes skill. And then knowing the tissue tolerance of how to treat it. And then critical element is actually empowering the patients to manage their own condition and do self-management. And then, by the way, alter that every time they come in based on how the patient's progressing, and moving them to the new and guiding them to manage their interventions as they based on the response to the previous treatment. So that becomes the strategy. Um, I think I want to just say kind of one other big deal is that, the stakes are pretty high from this. And then in 2018, there was this great group in a surgical journal, The Lancet, and they put a very strong group together, and that even includes in the fine print. You see people like Bart Code, people like Julie Fritz, people like Roger Chow, and these are real leaders, and Chris Mayer, real leaders in the publications and the practice of managing low back pain. And they're saying, hey, we got some challenges, we got some promising directions, but we also have, of course, the evidence. And the evidence is multiple guidelines recommend that self-management is the critical element for managing low back pain. I mean, it's the consistent that's across the board. The other thing, which has been really prominent in the last decade, is that, hey, there's physical and psychological therapies that if you use them, you do better. And also the big deal is less emphasis on pharmacological and surgical interventions because they don't work as well, and avoid routine imaging and investigations because it shows to basically not be needed, be expensive, and lead toward disablement. The nice thing is that the statement from, again, this is Surgical Journal saying, hey, there's little prevention literature exists with the only known effective interventions for secondary prevention, which means lessening the likelihood of your second low back pain or episode and third and fourth and continuing, is being exercise and exercise with education. So if you think about it, where you're looking at the sweet spot of how do you prevent the next episode of low back pain, that's your profession. And the only evidence that there is that, again, compared to the other interventions that are provided. There's another big challenge when it comes out here is that, hey, I don't know if you got the memo, but low back pain is the biggest cause of disability globally, so in the world. And the problem is it's been that way, even though billions of dollars has been spent on research in the last 20 years, and it hasn't gotten better. And the daily number of life years between 1995 and 2015 and 1990 and 2015 has stayed. The other memo that's coming across is, oh, by the way, what's the most expensive in society? So if you look at the data in the United States, more spending, the most expensive is on type 2 diabetes. By the way, how do you manage type 2 diabetes is with exercise and diet and lifestyle change and self-management. That's the biggest expensive condition, followed by other musculoskeletal disorders, which include joint pain and osteoporosis. So that is, that's our sweet spots. Now, another interesting study, of course, looking at something like chronic pain, which is highly related, of course, to musculoskeletal pain. The cost of that, you have to add the disablement that people are going through because it typically hits people at when they're productive, when they're a parent, when they're a worker, when they're a wage earner, when and basically in the 20s and 30s and 40s versus other conditions which hit people typically in the later part of their life. But if you think about the annual cost, and this was documented for this time period, the annual cost of managing pain was greater than the annual cost of heart disease and cancer and diabetes all combined when you look at the loss of productivity of worker productivity along with the amount it costs to manage the pain. So I only say this is that the challenge is something that we need to, I would say, take responsibility for and start upping our game with managing that. And the nice thing is, well, here's the challenge is that not evidence-based practice is apparent across all income settings. And when it comes to low back pain, the presentations to emergency departments and liberal use of imaging, opiates, spinal injections, and surgeries are part of it. The nice thing is there's nice directions, and part of it is focusing on best practice, which means typically fidelity to the clinical practice guidelines. The other nice things is redesigning clinical pathways of early access to self-management, self-efficacy training, which typically means get them to PT sooner than later. And that saves you money and that lessens disability. And the critical element of this is have the payment systems actually pay for what's work. That's not so easy, but actually pay for what is the most effective rather than paying for who has the biggest lobby, if you want to state that way, or economically. So that becomes this. So this concept of what is low back pain and why do we need to pay attention. And again, this is published in a medical journal, and they're saying is like, we got to look at low back pain a little different. That it's increasingly understood as a long-standing condition with a variable course rather than episodes of unrelated occurrences. And it's a complex condition with multiple contributors to both pain and associated disability, including psychological factors, social factors, biophysical factors, which is typically what most practitioners look at, the comorbidities, and pain processing mechanisms. And so here again, a medical surgical journal is saying, hey, this is what low back pain. And if you don't recognize that, you have bad outcomes. If you just look at the biophysical factors and treat what's on your image, good luck. It doesn't work. And so you have to, as a practitioner, have more skill of looking at all of these elements. And again, we're talking like, hey, the psychology, the view, the beliefs, the fear, and then also the social context, and then the pain processing mechanisms. So it's interesting. And so the call to action is, hey, we need to look at this and move away from an emphasis on biomechanical and fragmented model of care to promote the concept of living well with back pain, person-centered care, focusing on self-management, healthy lifestyles as a means of restoring and maintaining function and optimizing participation. So if you know anything about the ICF, those are actually ICF labels of activity limitations, participation, those type of things. And again, the personal factors of self-management. So let me stop there for a second. So Ben, anything going on in the chat? So we're good with that.
Nope, I think they're good with it.
Okay, so which is interesting. So let's look at where the low back guidelines drove us. Now, again, this is a contribution to leaders such as Tony DeLito and Steve George and Linda Van Dillen and Julie Whitman. I mean, these are all, again, leaders in back pain research and practice. And they were saying, I can remember Tony says, the last thing we need to do is to print out a 500-page guideline that says how to manage acute back pain. He says, because that's not the issue. The problem is the disablement that's associated with recurring pain. And the goal of therapists should actually be don't focus so much on that acute pain. It's going to probably get better in spite of what you do in most people, but there's some people that it doesn't. And we need to figure out what those some people are and focus our treatment on that. And by the way, that's what you need to do to reduce the progression from reduce the progression from acute pain to chronic persistent pain syndromes and that disablement. And so they nicely describe this clinical course from acute, subacute, recurrent, and chronic, and said, hey, you could put people, and you got to start putting high priority on interventions that prevent recurrence and the transition to chronic low back pain, especially when you look at the expense and disablement associated with chronic pain. And then they said, hey, what we're not doing so well is actually matching treatment to what the position people have, even at acute pain. And so we should probably start classifying people into mobility impairment. And that means maybe mobility deficits, or they move too much, or they have lack of motor control in the low back, thoracic, and sacroiliac regions, but also there's individuals with referred pain, which is that centralization, peripheralization, or there's people with radiating pain. So you're looking at more nerve-related pain. And then there's also people with generalized pain where it's not related to physical impairments. And you have these different elements to classify. With becomes these labels, and we use these labels right out of the ICF. And I have to thank Bob Johnson. He says, I said, Bob, what do we call these people that have this? Now I just use the word tendency because he said that's what it is. The people that basically have depression or they have fear of movement and they're anxious about it and they believe they couldn't move. And he says, well, that's kind of that's the cognitive, that's their belief, that's their thinking. So why don't we call it cognitive? And the nice way, the politically correct way to talk about mood disorders is how the mood affects everyone and affects them, the individual. So we call those affective disorders. So he says, hey, let's call this low back pain with cognitive and affective tendencies, and that's stuck. And he says, okay, well, that's what you see in acute pain. You have people with these tendencies. And by God, that predicts who ends up going on to disablement. And then the critical element is that these different classifications respond predictably to different interventions. So different exercises, if you look at that. So it's not all therapeutic exercise. Like you see, you can't really look at the CPT code because mobility people get stretching and manipulation. They have deficits. The coordination people take essentially coordination training of mainly their trunk and their hips and their, as you would call, core. Basically, they're stabilizing elements. The people who have referred pain, you get centralization, peripheralization management, and the people who have radiating pain, you do reduce the nerve entrapments and you do nerve mobility exercises. So if you can just match the exercises to the right dose to the right human, you do a lot better and actually empower them to manage it themselves. So it's building on the Robert McKenzie part about treating your own back, but modifying the exercises to what the person needs. And then you have this group with cognitive affective tendencies. So, by gosh, therapists, you actually need to know how to do counseling and education and focus on how to get people to move and lessen their fear of movement or address their exercises to address their depression and manage their depressive episode that's commonly associated with musculoskeletal pain. Because treating their impairments isn't going to cut it. And again, part of the skill, part of the Wolfgang Puck of this whole thing is actually knowing what people have, and they may have a little of both. They may have a few of each, a part of each of these. They may have impairments associated to each of these conditions, and how do you drive your dose to do it? And so when it comes to this cognitive and affective tendencies, again, it's much more related to counseling, education, motivation, getting people to basically move and have the skill and the confidence to move and not the worry that they're going to hurt themselves with it. And so the group that's that's the sweet spot of doing that is therapists. That's our physical therapists. And I can tell you, they're not going to get that kind of training from their psychotherapist. I mean, I have my degree in counseling and never once when I got my master's that they talk about movement or how to assess somebody's movement or how to train somebody's fear of movement. They're all dealing with substance abuse and social relationships and other tendencies that are not related to the movement system, if you want to call that, are not related to their ability to function in society. Now, and part of that is how do you classify those people? Well, what we used in the strategy here was what was published in the literature. There's the fear avoidance pain questionnaire. There's the depression scale. There's the catastrophizing scales. So these kind of things and the questions and the conversations that go along with it tends to classify people in those conditions just from listening to them and listening to their story and how they perceive their pain. And then part of your intervention is not do the things that we know and have been shown to promote disability, which is talking about their pathoanatomical problems, which may or may not be related, but don't give some people something to worry about. And the other thing, of course, keep them moving. We know bed rest. There's a lot of studies that say bed rest doesn't work. It's actually worse. And then actually counsel them on what you should, basically on how strong the spine is, the neuroscience related to pain, overall prognosis, which is typically good, the lessen the catastrophization and early resumption of activities, even when there's pain and not so much focus on pain. Certainly, not even talk much more about focus and give them affirmations for accomplishing their goals related to that, and then focus on those activity levels. So that becomes where we're going, and that's all related to acute pain. Because if you can manage that, you tend to not get into chronic pain. But if you get into chronic pain, here are the three categories that are related to these conditions: these movement errors, the radiating pain, and then the generalized pain. And the generalized pain, the main issue is they're not related to physical impairments. They're related to that you would find with the other categories, but it's more related to the presence of depression, fear avoidance, belief, catastrophization that's associated with long-standing pain. And then so your recommended intervention is activity, fitness training, prolonged, basically remodel their nervous system and then counsel them on that there's hope and that they can do it. And then actually you can remodel, and this is what you can do with exercise, this is what you can do with movement, this is what you can do with reframing how you're looking at it. Easier said than done. I'm not saying this is easy. This takes a lot of skill. And don't think that it does. I mean, I'm saying it in a very quick way, but I mean the same amount of skill you would put towards your manual therapy, you would put towards your exercise prescription, you would put towards your neuromuscular re-education, you probably need to put towards your counseling because that's and your education because those are the patients that probably that need it most. So what I can proudly say is what we're doing, and it's in the process. We're making a clinical practice guideline to help provide guidance to individuals. I mean, all practitioners, not just physical therapists, but all practitioners that are managing people and working with individuals with acute and chronic musculoskeletal pain. So that's on the agenda, and that's that this is not an easy one, but we're working on that. And again, I just want to mention that all of these guidelines are free access, and this practice guideline package of how to make it come alive, how to make it gamification of it, and have it be interactive, how to have videos, have it all be something that you can get on your iPad and click through rather than trying to read a PDF. So that's where we're heading on this. So comments, feedback, questions?
So I have a question, Joe, is you're encouraging people across the country, residents, fellows, faculty members, to engage in the study of an application of the clinical practice guidelines. Are you finding that there is a data set? Is there research saying, yes, if you do those things, you are going to get better outcomes, you are going to see downstream cost of care savings and things like that?
There currently is. Let me put it this way, there's reasonable data. That's what was even they found in the 2018 study. Reasonable data that says, hey, if you follow the guidelines, your outcomes are better than if you don't. And those are essentially population-based research, typically coming out of Intermount Healthcare and coming out of Pennsylvania, out of Pitt, those type of studies. So it's mainly Julie Fritz and her crew and Tony DeLito and his crew, Now, what we need what we need in this day of AI and this day of being able to look and aggregate data is to start looking at the notes and do chart reviews and to be able to have a registry or repository of 10,000 cases of heel pain. 10,000 cases of back pain with mobility deficit, have the ability to actually, from the note, classify people into the conditions according to the guidelines and see what people do. Don't even tell them what to do, just see what they do and see, oh, what are the positive deviants? The people that had the best outcomes per visit, what are they doing versus the people that had worse? Because we need that to be able to revise the guideline and say, oh, here's what actually in the world is working best. So that's the next push. So I'm going to come to the Jackson clinics and say, okay, we need to have that be part of your data collection. And multiple clinics. I'm going to say, hey, here's the package you need to do. How about using this software system, this documentation system, which actually is probably easier than others because you click through and you get the stuff already done and use that and then actually contribute to the repository. That's getting easier and easier with AI. So that's where we're heading. I don't know if that's answered your question, but I'm just kind of saying that's the That's needed. I'm going to say not to even say what we're doing is correct, because what we do in a randomized trial with 100 people is not, we don't know if that's right in the world. And it's much better to look at 10,000 people or 20,000 or 30,000 people and look to see what's actually has good external validity, and what should we and how should we revise our guidelines. I mean, that's so then, and maybe combining a few things might actually be the right thing rather than just doing one thing that you would do in a randomized trial to be controlled. Anyway, does that make sense?
Yeah, no, that's great. And obviously the next step after that is, let's assume that those who know and do what the guidelines would recommend and who classify people the right way and deliver the right intervention to the right person at the right time, how do we build those people? How do we, as this cohort of people on this call and the many who will watch the recording are the type of people who want to be excellent in the profession and who want to be at that cutting edge. And so certainly reviewing the guidelines is one. You mentioned a couple tools. Can you expand on that a little bit more, how they can go and really find those resources to sharpen that up?
Let me answer this two ways. And you know the first one better than anyone, probably, or better than most. The first thing is actually you have to financially affect their wallet if they do it or not. You know what I mean? If you're paid for being stupid, why would you be smart? I hate to be so blunt, but you know what I mean? I mean, and if
That's
you
a great
weren't,
quote.
you know, I mean, if you aren't, and your wallet depends on you actually learning and being skillful, all of a sudden you do. I mean, physicians get practice at a high level. Why do they do that? Because they know they're going to get sued if they don't. You know what I mean? And we just no one's suing anyone. I hate to be so blunt. No one's suing the therapist that led somebody down the path to be in chronic pain. You know what I mean? Even though it's disabled their life, because we don't have that knowledge out there. So that's one thing. It's basically changing pathways. But part of changing pathways is showing in the evidence that it really makes a difference. And so the payers will alter that. I mean, that's ideally, that's the thing. Mainly the self-payers. I mean, other payers where it's you're rewarded for reimbursement and billing, that's a very difficult nut to crack. And but I think anyway, so let's say assume that there's the motivation. Generally, I think I will just say it's really hard for people to know what to do different if they don't follow somebody and if they just do what they're doing based on trial and error. So my big push, and that's actually why, I mean, my big push, but a lot of people says, hey, we need more clinical mentors out there that are doing it, that can actually do the training. But now we're trying to empower them in this digital age with, oh my gosh, here's the support of how to do it. Here's the skills that are required related to guidelines. For example, I think people should be learning not what are the exercises for the knee, but what are the exercises matched to each condition of the knee, and have their school be taught, oh, you have an anterior cruciate ligament problem or ligament instability. Here are the exercises you should do for that. Oh, you've got a cartilage meniscal loading problem. Here are the exercises you should do for that. Oh, you have and the progression. Oh, you've got a hamstring strain. Here is the progression for that. I mean, I think we should remodel our education to conditions, not basically body regions. And we should say, oh, here are the examinations you do to rule in and rule out rotator cuff tendinopathy and here are the examinations for adhesive capsulitis, here examination for shoulder instability. And then here's what they tell you that gives you the clue you should actually perform that exam. Somebody who says, I mean, when somebody walks in the door, it's not rocket science that the story that somebody that has a heel pain is going to be different than somebody who has an ankle sprain. It's going to be different than somebody that has Achilles tendonitis. So you should go right to that exam that's going to rule it in and rule it out, and then right to your interventions and see if the interventions work, and not and have that be done in 20 minutes and empower them. You can do this. And I would even say that with low back pain. So then the person who has it say, oh, This isn't so complicated. I can do that. I guess I'm just weak. I need to get stronger. Yeah, I mean, good news. You can get stronger. Or I'm stiff. I can gain more flexibility. Yeah, you can. And by the way, I can help you. I can manipulate right here to give you some, get you on your way. But by the way, you got to do it too because this gets ugly if you don't manage it. And so I would say creating clinical supervisors, empowering educators with being sensible, how to create train. When I say sensible, organize the knowledge so this is like the critical stuff people learn versus, and actually, by the way, make sure that that stuff is what's tested on the state board exams and have that be driven so then the schools teach that because that's the best practice. So kind of work in that way and actually move towards actually rewarding people who have guidelines. And that's kind of where actually the AOPT or APT Orthopedics is trying to head, is move people towards that of giving rewards to people who know it. So then when the payers start to ask, oh, who knows guidelines-based care, you can hold your card up and say, oh, I do. Just like you couldn't get a job in an emergency room or as a paramedic or as a ER doc, as a nurse or a doc, if you weren't advanced cardiac life support certified and you didn't know the guidelines of the American Heart Association. I would say, you probably shouldn't treat somebody with low back pain unless you know the guidelines from the AOPT if you're a physical therapist. Just like I shouldn't treat a kid with torticollis unless I know the guidelines of the pediatric therapy on how to manage torticollis. Do you mean I'm dangerous if I don't know? I really shouldn't be paid for treating a kid with cerebral palsy or with torticollis or with spina bifida unless I really knew their guidelines and actually had some knowledge and skill in that. Anyway, does that make sense,
And
Ben?
and are you seeing that that's you mentioned a little bit, but is that the direction the academy is going?
I'm strongly nudging them and they're saying yes slowly. So yes, we were going there and that all of that practice guideline package, the big focus of that was actually, oh, this is the way to help academic institutions prepare students. And by the way, we give students free membership and we give students free access to all of this guidelines information. And we want them to learn that. And then, by the way, oh, here's the card you get when you pass an exam that says that you know what, that you have knowledge proficiency and skill proficiency if your school teaches the guidelines related schools. And we have content to empower them to do that. So we're trying to head that way. And with the concept that, hey, the neuro section should do the same thing. The cardiopulmonary should do the same thing. The geriatric section should do the same thing because they all have kick butt guidelines too. And so as you're moving into figuring out where you're going to be spending most of your time practicing at that time during that part of your career, you actually should be proficient, knowledge competently, and skill proficiently in those areas of practice. So that's the
Love
direction.
it. And so where do you think this falls in comparison to something like board certification?
I think board certification is a higher level because not everyone fits the guideline. Cardiologist needs to know more than just emergency cardiac care, And so I would say, physical therapist that's board certified needs to know more than just the guidelines because not everyone fits the guidelines. What we created guidelines are about what we have evidence for. But by the way, you still might see somebody with D veins in there. We don't have something for that. You might still see somebody with patella tendonitis, and by the way, you have all these surgical conditions that you manage, which there isn't very many guidelines about that because it's pretty clear about what to do for them. Do you follow? There's not that much decision. You already know the tissue and you just got to basically help the tissue heal. So that would be the element. And what I would also say where board certification would even be higher level is that you actually have a practice element that would put you at a higher level of proficiency just like your residents are actually doing something under care. You and I could read the books and become an orthopedic surgeon and pass the written exam. But you and I don't want to be. You don't want to be given a knife. You don't want to have the knife in your hand and be responsible because you aren't trained in that skill proficiency. Where a residency and fellowship would really help you in training that skill proficiency. Does that make sense?
Definitely. And as you're putting together this clinical practice guidelines package and trying to translate it from strictly knowledge into practice, what are the things that are being done to help that skill-based proficiency as well? So let's say you are a, you know, guideline certified therapist. Is it only knowledge based, or is there a skill based component as well as you're imagining it?
So the where it sits now, and this is where it is basically for each of the guidelines, there's a list of skills that relate to movement analysis, relate to examination, relate to intervention, whether that be exercise or manual therapy. And there's for each of them. And there's video component of, oh, here's the movement error, here's the correction. Oh, here's the examination. Oh, here's the manual therapy. And that's all like part of that package. So here's the video of it. And so the concept is that actually, if that's taught in an entry level program, and we, let's say like, 90 hours in an entry level program, then they would be in that they show verification that they're teaching those skills and they're testing on it, then that person would be skill proficient. Or they can get that same information, of course, in residency programs where it stands now that anyone who's in an orthopedic related residency program or fellowship program automatically is assumed to have skill proficiency. The other option is that there's seminar series, which are, kind of what you guys teach, which actually can be AOPT credentialed to say, oh, we teach the seminar series that teach those skills. And so just for example, I mean, I talked to somebody in your neighborhood, Ken Johnson at Johns Hopkins, kind of your neighbor, he says, oh, Joe, why don't we do that and be one of those places that do teach, we teach the skill proficiency for the guidelines in our residency, our seminar series. So let's do that and then offer it for people in the community, not just for residents to come for it and then come and learn that and then have that, let's say, extra badge that they actually have skill proficiency. But to get the skill proficiency, you need to also have the knowledge. You'll also have to pass the knowledge exam, which essentially is going to be a 50-question multiple choice exam that covers all of the guidelines that you can take relatively free access to the work. I mean, that'll always be changing, but it'll just be keep getting updated. And every 2 years you take that online and get re-credentialed. Does that make sense as far as the skill proficiency?
Yeah, for sure. Especially because you do updates to the guidelines every 5 years. How often?
It's supposed to be at least about every 5 years. I mean, at least at 5 years or somewhere around there. And so we're getting better and better at how to basically make updates and don't have them be so long and arduous to read. And so that's the goal where they continually update. So that's the intention of, oh, that's where you need to say, oh, what's new in heel pain, what's new in back pain, what's new in neck pain, and what did the evidence change, and what makes it more, how did the recommendations change based on the latest evidence?
Yeah, that makes total sense. And as I envision it, maybe the last step, you've got the knowledge bucket, you've got the psychomotor skills bucket, and then there's the putting all the pieces together, right? That mentorship component. Have you started thinking about, or building essentially a network of clinical practice guidelines, accredited PTs who then kind of share data, bounce ideas off each other, somewhat of an informal or maybe even a formal mentorship process?
That's a real interesting question. I mean, because if you think about it, think about what we were taught clinical reasoning was. And I will say that whole reasoning process kind of failed. And that was even in our, look at the stats on musculoskeletal pain. If we had better reasoning, we probably wouldn't be the failures of society. Do you know what I mean? So what should we teach? And so I would say actually, yes, those guidelines-based practitioners, I don't have a good handle on that yet. I'm still getting these things out. I'm going to try to push, as always, like, oh, that's what residencies should be, and focus that should actually what our clinical instructors, what we need is really good clinical instructors, to actually model that say it makes a difference. So and I think that's what residents, that's a that's a sweet spot, I would say, of residents because they learned how to be a good clinical instructor because they went through the process themselves. So I would, I would, I would try to empower them as much as possible. But a lot of them, what in many schools, those residents, graduates tend to be ideally the ones training the entry level part-time. I mean, they're volunteering their time to doing that. And so having that be part of it is, I think, just getting out there. I will say, to be, again, kind of with your thing, I think the more we have this affecting people's pocketbook and motivating them, the more creative people will be to do it rather than do it because you want to be good versus do it because if you don't, you're not going to get paid. And I'd like you, I hate to be so rude, but if you couldn't get a job unless you were guideline certified, that would change the whole nature of people trying to learn. You know what I mean? Just like in cardiac care, in medicine. Do you follow? I mean, but we need to create those animals and then do studies on that and actually show that with AI and data registries that actually is, and then have payers say, oh, this is what we should do, and actually only send people who are in the directory of the AOPT when it comes to musculoskeletal, or in the directory of the Neurology Association when it comes to stroke and spinal cord and Parkinson, and in the directory of pediatrics when it comes into developmental delay and autism disorders and torticollis, those kind of things. So I think that the more it gets driven policy wise, the more standards be more consistent. My little example of cardiac care, that's being driven because of policies. I mean, in California, I can't get licensed as a therapist unless I know CPR. Talk about, I need to know the Heart Association guidelines. I don't need to know my own association's guidelines. Talk about the poster children of guidelines implementation has been the Heart Association, and I think we should start to look at how to follow what they're doing.
Love it. Very, very stimulating conversation. Exciting to see the direction that we're going, thanks to your lead and the lead of others that are in your group. Thank you, Joe, for taking the time this afternoon, your afternoon, our evening. Really, really appreciate it. If anyone else has any questions in the chat, feel free to throw those in. Otherwise, thank you all for taking time on a Tuesday evening as well. Stay tuned for future residency hot topics. And Joe, thanks again.
You're very welcome. And you guys have a handout, kind of outlines what we kind of talked about in these last few minutes just with this discussion. And you can just read through that and use the resources that are available to you. So all the best.
And we'll stay on for any final questions as you send in, but otherwise have a great evening. Thanks, guys. Joe, it looks like one more question did come in. Mike just asked, how would you respond to the worry that teaching a specific set of exercises would be perceived as cookie cutter, since we're taught this was a bad approach?
I would just answer, I am so novice at cooking. I need the Betty Crocker cookbook. I need the cookie cutter. But if I'm going to get paid to do this, if I'm working somewhere, if I'm getting paid to do this, I need to be Wolfgang Puck. So I'd say, hey, you need to take that to a new level and even look at exercise patterns when it says, hey, yeah, when you need hip external rotation strengthening, here's one of 18 graduated events. You got to pick the right one. You got to show them how to do it, and you got to decide when to progress them to the next one and actually guide them on how to know when to progress. So the skill is actually empowering people to do it rather than sitting there showing the cookie cutter. It's actually the empowerment and giving them confidence that they can do it and manage their condition. That's why I would say the skill is not even what exercise to do it, but just having the patient walk away saying, I need to do this. So if you get someone to walk away
right and say, to progress and regress based on irritability, right? It's all those other pieces, not the selection always is the skill, it's the implementation.
Yeah, I think that's the new reasoning, Ben. The reasoning isn't just matching, oh, you have a hamstring chair, do Nordic hamstring exercises. Okay, or you've got patellofemoral pain. Oh, do hip external rotation and quads. It's like, okay, wait a minute. There's a little more to it, and yes, you got to do that. But what dose? How do you do it? At what level? By the way, when do you get the foot involved? How do you take it into a loading response with the type of running you do, with the type of shoe you have, with the type of foot you have? all of that is very different. It's more than just the cookie cutter. And so I think that's what I like about the guidelines. It says, oh, here are factors to take into account, and this is part of the recommendations.
Great. Thanks again, Joe. Until next
Okay.
time. Much
All right,
appreciated.
Ben. Take care. We'll see you.
You guys.